Hey, good evening. Hope my voice is audible. Good evening, Ramesh sir. Good evening. Good evening, everyone.
Good evening, sir.
Good evening. So we'll give one more minute of time, Oma, by any chance. One more minute we'll give. Sharply by 8:02 we'll start because I think people are joining now quickly. So we'll wait for one more minute. Ramesh sir has joined.
Yes, sir.
Okay, Ramesh sir is.
I joined. Wait,
Yeah. Good evening, sir. Good evening.
I joined.
Yes, sir. Yes, sir. We'll give one more minute, sir. Sharply, we will start by 8:02. So people are joining quickly. So we have shared the links. So they are joining. We'll wait for 1-2 minutes more, and then we'll start the session. Good evening, everyone. Thank you for joining the live session. So we'll be starting in a minute. We'll have very interesting sessions today. Oma, I think we can start. Uh, Kavya is there.
Yes, sir.
Okay.
Just a moment. I'm checking with Kavya.
Yeah. This is live in YouTube also, and people have joined in YouTube also. Uh, Good evening, everyone. Thank you for joining. We have wonderful sessions packed up, lined up. So just allow us a minute of time. We'll be starting a session. So we'll be having first session for 20 minutes. Then Ramesh sir will be taking ahead. So he'll be speaking more about the clinical pharmacy practice. What is this best practices for clinical pharmacy? And he comes up with a lot of experience in real time of clinical pharmacy practices, and he has established so much of clinical pharmacy practice, and he is the current chairperson for hospital pharmacy division in Indian Pharmaceutical Association. So we are excited to listen from sir about the latest advancement and how the things are being changing. I think Uma. Okay, so without any delay, let's start the session. Um, Ramesh sir, I'll be taking over the
Just
session.
a second, sir. Kavya has joined. She'll be giving 1 minute of introduction.
Oh, okay. So I'll stop my screen. So
Yeah.
because I think we were late, so I thought I'll start the session. Okay.
No problem, sir. I'll
So I have
start.
stopped the sharing. You can quickly share the screen.
Yes, sir. So, hi, first of all, hi everyone. Thank you for joining. I am Kaveshri from Clinosol team. I welcome you all, and we are delighted to have with us Dr. Ramesh Adepu, Chairman of Hospital Pharmacy Division (IPA), who will be sharing his valuable insights in this session. And I would like to give a brief on Mujib sir now.
Go ahead, Kavya.
Yes. Yes, sir. So, the CS Mujib sir is a distinguished professional with exemplary academic foundation holding M.Pharm and MSc in clinical research. So, with over 18 years of experience with globally recognized organizations such as QPS, Paraxel, Accenture, Oracle, and IQVIA, he has emerged as a leading voice in the clinical research industry. So, guided by his strong passion towards education and the mentorship, he has established Clinosol Research, which is a platform where so many students have made wonders, and he has bridged the gap between academic knowledge and industry demands. Through this organization, Sir has mentored over 1,000 students and placed them since 2019, empowering them with skills and confidence. His commitment to advancing the field extends beyond the classroom, and since 2020, he has actively participated in premier industry conferences such as ISCR, SCDM, and ACRP, serving as an academia partner and contributing to valuable insights to the global clinical research community. Currently, Sir is working in multiple leadership, focusing mainly on the clinical research as a founder and CEO and associate director for SGP. Under his visionary leadership, Clinosol has earned widespread recognition and has been honored with 13 prestigious awards, underscoring the organization's excellence in clinical research, training, and workforce development. Rena, renowned for his engaging and authoritative presentations, Sir is a sought after speaker at national and international academic and industry forums. His sessions are known to deliver not only knowledge but also inspiration. So now I would like to introduce about our speaker, Dr. Ramesh sir. I'll share it again. Sir, would you like to say anything, or I shall introduce Dr. Ramesh sir?
I think anything is fine. If you wanted to introduce now only, so I'll hand it over to Ramesh sir. You can introduce now only, sir, and I'll complete my session quickly.
Okay, sir. Okay. Now moving forward to our speaker, Dr. Ramesh Adepu. Sir has a farm and a PhD, and Sir is graduated from Kakatiya University in 1987. He was the first batch student of M.Pharm Pharmacy Practice from JSS College of Pharmacy, receipt of the VIMTA Gold Medal at M.Pharm, and the country's first doctorate in pharmacy practice. With a glorious career spanning over 2.5 decades as an acclaimed academician and researcher at Department of Pharmacy Practice, JSS College of Pharmacy, Mysore, taught undergraduate and postgraduate students, supervised their research, and coordinated national and international funded research projects. Currently, he's working as principal cum director at Vikas College of Pharmaceutical Sciences, Suryapet, Telangana, which since 2017. As the immediate past Vice President of Indian Pharmaceutical Association and Chairman of the Hospital Pharmacy Division (IPA), he has been a key resource of numerous training programs, national and international conferences, and workshops on pharmacy practice, maternal health, and pharmacovigilance, among other topics. So he's actively supporting capacity building and training practicing pharmacists and PharmD students. He has guided 60 postgraduate students, 75 PharmD students, and 2 PhD students, apart from delivering presentations in various national and international forums. He has over 62 research publications in various peer-reviewed national and international journals, 3 textbook chapters, and 1 textbook to his credit. He supervised more than 50 lakh worth of research grants received from UGC, AICTE, and ICMR. He is a lifetime member of Indian Pharmaceutical Association, Indian Hospital Pharmacist Association, Association of Pharmacy Teachers of India, and an international member of International Pharmaceutical Federation, Pharmaceutical Society of Australia, American College of Clinical Pharmacy, and American Medical Writers Association. Under his guidance, Taiki Innovations Private Limited, a startup company in Vijayawada, developed and marketed a clinical decision support system software under the name of Clinorix. On September 5th, 2022, the Telangana State Pharmacy Council gave him the Best Teacher Award. In recent IPA election, he was elected again as Vice President of Indian Pharmaceutical Association and Chairman of the Clinical Pharmacy Division. So with that, I would like to give this to Mujib sir, and he will take forward. Thank you, sir.
Yeah, thank you. Thank you everyone for joining and staying back with us. I'll take another 15 minutes of time exactly so that the topic of Ramesh sir is being focused. So today's topic I wanted to take on the role of chatbots in pharma and also clinical research. So chatbots have become more famous. It's one more time, it's called as chat GPTs or automatic bots. So chat GPT is being more used than anything else now. How chatbots or chat GPTs can be used in pharma and clinical research, I'll be speaking in this another 15 minutes. So this is my topic. So what is exactly chatbots? The AI-powered tools which can give human conversation. It can include Siri, Alexa, and healthcare-specific chatbots like Ada Health. So we have already healthcare-specific chatbots, which is called as Ada Health. And we all knows about the Siri and also Alexa. So why they matters in healthcare? Why should we use those chatbots in healthcare or chat GPTs in healthcare? Either to first patient engagements to improve and to reduce the cost, and the second one, improve or enhance the efficiencies across the healthcare systems. So these are the few advantage of using the chatbots in healthcare system and pharma and also in clinical research. So that's the introduction. There are types of AEs or types of AIs, which are artificial intelligence, and where the chatbots fits. On the top layer, it's super intelligent AI, which is purely theoretical. But the middle AI, which is called as generative AI or general strong AIs or hypotheticals and human-like intelligence will be there. And the next one is narrow AI, which is chatbots and specific tasks, they'll be able to do it. So chatbots come into narrow AIs, the narrow artificial intelligence, where it can respond to all the questions which are being asked. Whenever you ask a question, it splits into part to part. It understands and it responds back with the solutions. That's your chatbots. How chatbots can be used in healthcare system? The first one, symptom checking. The tools like Ada Health or Babylon Health helps the patients to identify the potential conditions based on the signs and symptoms. Now, say, for example, if you give some conditions and symptoms, it might go and tell you what is the conditions you might suffer. The results might be accurate. I think around 80% of results will be accurate. It can also appointment scheduling. It can be used as appointment scheduling when patient wants to schedule an appointment. It can go to back to the system and it can book an appointment to the nearest doctor. So say, for example, if you are a patient and if you are searching for a skin specialist near to your area and you have a psoriasis problem, you can put it in chatbot and then it will go and book an appointment. So scheduling an appointment is automated booking, and reminders also can give improved patient attendance rate and also compliance of the patient. The third most important one, which everyone is speaking, because mental health is one which is not been spoken more, it is ignored more, and it is having so many issues. Mental health support platforms like Ubot provides the accessible psychological assistance. So which at any point in time, you can go to chatbot and it will give mental health support to you, because it's not a human being, it's a machine which can support you. So these are the three things where you can use in healthcare. Particularly in pharma industry, how can we use it? So in healthcare, I have spoken about how you can book an appointment and how you can understand the conditions and how you can use it for mental health. But how you can use in pharma? The first one, you can use it for knowing the drug information, provides the accurate medications and also adherent support to the patients, compliance of the patient drug usage. That's the first one. The second one, it can be used for clinical trial recruitment where patients are there and they don't know which clinical trial they wanted to participate. Then clinical trial recruitment guided potential participants to relevant trials matching their conditions. Say, for example, if you go and say that, okay, I have this conditions A, B, C, D, can you put it me into any of clinical trials? Then it goes and searches the clinical trials which are already available at the nearby, and it can give preferences. Okay, you can go and enroll into this trial and give details about the trial to the patients. The third one is professional support. It can assist the healthcare professionals with product information and resources. Say, for example, we might not remember all the information about the drug product. It can help healthcare professionals to support to give the treatment to the patient. So professional support can be given to the patients. Now, specifically chatbots in clinical research. How chatbots can be used in clinical research. First one, it can give a patient engagement and enrollment. And also it can collect the data from the different sources of the patients. First is you can enroll a subjects, patients into clinical trial, streamlining the recruitment process so that exact patients are matched and there is a failure rate is very less. That's the first point. Second point, you can collect huge amount of real-time information from the patients throughout the study. That's the second point. The third point, ongoing engagement. It gives you more engaged that participant does not leave clinical trial. Engagement is more important and it can go and participate and continue into the clinical trials. Provide trial updates, maintain documentations, and also communications with the participants. These are the three important uses of the chatbots in clinical research. Okay, the background of chatbots, they uses the query language and also the natural language processing, which is NLP, and they might use response generations and user receiver answers. It goes get the questions, split it back and gives the responses, and also it creates more data into the system so that it can be used for further things. So the first one, patient inputs the question and query. The system understands the human language, splitting it. And the third one, it gives a response. The fourth one, user who has asked a question gets the answer. That's the 4 points, which is background of your chatbots. Now, what are the biggest advantage of chatbots? The first one, it can be used for 24/7 access to healthcare. It can give personalized and immediate responses. That's for patients. For healthcare providers, it can reduce the administrative burden and remember all the papers and documents. It can improve the patient engagements because it gives the complete reminders. It lessens the work of the patients. For pharma and research, it can go for faster patient recruitments and also cost-effective and scalable solutions. So that's where the advantage of chatbots will come into it. Now, this is about chatbots and augmented reality. You can use augmented reality, which is AR, VR. The enhanced medical training can be done. You don't require a patient really to understand the trainings. You can have augmented reality wherein you know that really patient is there. You can go and do surgical assistance also. So if you have a VRs, you can go for surgical assistant, and you can have virtual health assistant also, where guide the patients through the physical therapies and exercise and medical procedures, where patient will wear this and the doctor is really talking augmented reality, talking in front of patient eyes, and then it goes on with that chatbots. The chatbots in actions transforming the healthcare. So initial patient contact can be done, symptoms can be assessed, care recommendation can be given, follow-up support can be given. All these things can be done with only one word, which is called as chatbots. The chatbots development is more important needed now. The patient contacts, symptom assessments, care recommendations, and follow-up supports. This is machine learning powers of chatbots. It first gives trainings and then NLP process, user interactions, feedbacks, and improvements. These are all the rotation steps which chatbots uses to understand how it can give generative AIs. The biggest problem, the challenges and ethical constraints. The first one, privacy of the data, because we are working with human data. The second one, information accuracy, how much accuracy the information is. The chatbot is giving answers. The adoption resistance, we are still not ready to adopt, and resistance is more. And the fourth one, AI transparencies, we are not able to take the decision-making process clear and understandable. And bias preventions, ensuring fair and equality responses, it's bias responses, bias prevention. These are the challenges and ethical considerations in it. The future, voice-enabled assistants will be there. It's about chatbots. Now, immediately you will get a voice assistant. The wearable integrations, including the sensors, wearables, watches, and all. The next level is predictive analytics, like the data which you have given, it understands and it gives the futuristic aspect. And also the personalized medicine, which is called as the precision medicine, individual-based, tailor-made treatment for the patients. Now, I'll be speaking about a couple of minutes for Clinosol. It transforms the clinical research careers. It's in Hyderabad, a premier clinical research training organization which serves career catalysts for life science and also pharma professionals. Our job-oriented certification programs for clinical research, pharmacovigilance, data management, medical writing, and regulatory affairs. We connect trained professionals with leading software organizations. These are the training programs which we give. We provide trainings on clinical research, pharmacovigilance, data management, medical writing, and also regulatory affairs and AI in healthcare and imaging research. These are our achievements. We have reached more than 50,000 students. We have more than 2,000 students who have already placed, and also our alumni are there. It's 4.9 Google rating and 87% of placements with top life sciences companies. 13 excellent awards, 45,000 of LinkedIn, and 125 engagements, conferences, including national and international conferences. So these are publications and blog. We have published more than 250 research papers and papers, 700 plus industry blogs, and 750 plus presentations we have given. And this is 360 degrees skill trainings, mentoring, career guidance, and job placement guaranteed. Join us for a free demo on the 14th of June. Register now, attend demo, launch your careers. So with that, I think I have not taken much time. Thank you so much for joining. I would like to invite now Adapu Ramesh sir, who will be going and taking the session. We'll be having one more live masterclass with Ramesh Adapu sir going forward. And we'll be giving more details on it. Ramesh sir, over to you. Ramesh sir, you're there? I'm open for questions. If any questions about chatbots or use of chatbots in healthcare systems or in any of pharma industries, you just let us know. I'm able to see any questions in YouTube as well as in Zoom also. So you can ask any questions till Ramesh sir takes the session back. We are open for questions. Ultimately, the story starts like this, that the chatbots are being used more and more for conducting more of clinical trials and also in pharma research. Ramesh sir, I hope my voice is audible now.
Yeah.
Perfect, sir.
Am
Over
I
to you.
audible?
Yeah, over to you.
Okay. Thank you. Thank you very much, Mujib. So good evening to everybody. It's very nice we met all of you. And today I would like to make a presentation regarding the clinical pharmacy practice, which is my favorite topic. And as I put a lot of my time, energy, and my expertise in that area, so which I wanted to share with you. So straight away going to the presentation. Today I'm going to discuss on clinical pharmacy practice, a tool for better patient care. Me, Dr. Ramesh Adapu, currently I'm the National Vice President, Indian Pharmaceutical Association, and also I head the Hospital Pharmacy Division in the Indian Pharmaceutical Association. This is my mail ID. If you have any questions, you can just shoot those questions, or if you have any doubts, clarifications, you can definitely talk to me. So let us move on to the presentation. Now, whether it is doctor, whether it is nurse or clinical pharmacist, whoever it is, or the pharmacist in the hospital or even in the community settings, wherever it is basically for providing the services to the patient. So let us have just a clarity about patient. Patient is an individual who is suffering from an ailment. So obviously needs the diagnosis and the proper treatment. Of course, more important is the care. So here, in order to provide the patient care, there are different areas, like for example, once the patient gets an ailment, will consult a consultant or the doctor. So doctor generally puts his expertise in identifying what is the major clinical condition of that individual by using the physical examination, laboratory examinations, radiological examinations, and all these examinations helps him or her to understand the patient clinical condition and comes to a final conclusion, what we call it as a diagnosis. Once a diagnosis is made, the next step is very important step. It is giving the prescription. Because all of us know the doctor may be highly qualified, expertised, experienced. He can only or she can only come to the stage of making a proper diagnosis. But to treat the patient, what is important is the medication. Unless otherwise the surgical intervention is required. Otherwise, the medicines, even after the surgical intervention also, the medicines are very, very important. So until the process of diagnosis, giving the prescription, whatever the efforts the doctor put on the patient is called as the medical care. Once the prescription is given, the patient takes the prescription to the pharmacy. Here, actually, the pharmaceutical care starts. Like the definition of the pharmaceutical care, it's a very, very important definition, which is given by Douglas C. Hepler and Linda M. Strand. These were the professors who worked almost a decade time to give this definition. In fact, they have written a book on the pharmaceutical care itself because they have 1 decade experiences conducting the research on the patient care. They have made a wonderful book. So I'm just taking the definition of this pharmaceutical care, but this itself, as a pharmacist, it's very, very essential for every pharmacist to understand the meaning of this definition. The meaning of this definition says it's a responsible provision of the drug therapy in order to achieve the definite therapeutic outcomes which improve the patient's quality of life. As a pharmacy professional, honestly speaking, it is my Bible, it is my Quran, it is my Gita. Because as a professional, if I want to deliver the professional services, I must understand what exactly my profession is. As a pharmacist, all of us know that we procure the medications, we stock the medications, we fill the medications, and we dispense the medications. But more important is monitoring the patients. How these medications are really helping the patient. By any chance, the patient, he or she is suffering from any unwanted effects due to the medicines, which we call them as adverse drug reactions. The objectives for which the medicine is really providing to the patient are not. And by virtue of taking the medicines, the patient's signs and symptoms, have they reduced or under the control, or they're completely healed from the disease, that improves the patient's quality of life. These is called as the definition of the pharmaceutical care. Because pharmaceutical care, we just simple definition we have read, but in order to understand, it is not just taking a prescription, reading the prescription, then analyzing are there any drug related issues, or medication errors, or the prescription errors, understanding all them. In case if any prescription errors are there, we should have that courage to call back the consultant or the prescriber, convey what errors you have observed in a very polite fashion, let the prescriber understand the intricacy of that error, and then make certain changes, what is needed for that prescription to make it as a proper prescription, and allow the pharmacist to dispense the medicines appropriately. It is not that just only dispensing the medication. It's more important is making the patient empowered with the knowledge regarding the medication and empowering them to use the medication more effectively. See, that is very, very important. Not only that, monitoring the patient for the safe and effective use of medicines so that the disease is totally healed or the symptoms or manifestations are under control and the person has come back to the normal in his life or her life so that they can become highly productive. So this is what exactly is the pharmaceutical care. Not just filling the prescription is the pharmaceutical care. And this is the philosophy and it's a practice. Why we need to have this pharmaceutical care? Because just now I said, pharmacist identifies, resolves, prevents the actual and potential drug-related issues. Here, what are these potential drug-related problems? Does there any problem happen with the drug? Yes, we come across so many drug-related issues. What are those drug-related issues? The drug-related issues, there are 8 categories. These 8 categories of the drug-related problems have been devised by the Hepler and Strand only. And then these 8 categories includes overdosage, adverse drug reactions, drug-drug interactions, drug use without indication, untreated indication, improper drug selection, subtherapeutic dose, and failure to receive the drugs. Just I'll explain to you what do you mean by the overdose. Here, see if any particular medication need to be given in its dose, what is required for the individual. In general, the doses which are available in the marketed preparations, they are made as per the average body weight. It is 50 kilograms. And according to the age, for example, we can, based on the age, we can classify the individuals like neonates, pediatrics, adults, geriatrics. So, for example, if you use an adult dose for a geriatric patient, pharmacokinetics are going to change in the geriatric patients. So obviously, the normal dose for adult patient becomes an overdose for the geriatric patient. So here, what is important for a pharmacist to understand the age and body weight of that individual and the functioning capacity of the internal organ. Based on that, the dose can be modified or adjusted. That is what is overdose. Adverse drug reactions. Any drug which is used in its normal therapeutic dose, either for the purpose of healing a clinical condition or for the purpose of any diagnosis purpose or an examination purpose or for just mitigation purpose, in case if the individual experiences any unwanted, unintended, unexpected effect which is causing a damage to the individual health, then it is called as adverse drug reaction. And these adverse drug reactions don't undermine them, just it's an adverse drug reaction. It may be starting from simple rashes to deaths. It can cause even deaths. And don't undermine the adverse drug reactions, because managing the adverse drug reactions in US itself alone, every year they spend $200 billion, and which is much more sufficient to treat all cardiovascular diseases and the metabolic disorders. Just imagine the amount which they are spending in managing the adverse drug reactions, not treating the clinical conditions. Drug-drug interactions. More than 2 drugs, when they are given, the patient takes them simultaneously, there is every chance either kinetically or dynamically. The drugs can interact with each other. The effect can be positive or negative. Say, for example, positive, say, potentiation effect. So there it is good, but there are situations these effects are negative, totally altering the effect of the other drug. It sometimes is going to be very painful, or it's going to be just nil action at all. These kind of the drug-drug interactions, for example, rifampicin. If a lady who is taking the oral contraceptives simultaneously uses the rifampicin, there is every chance rifampicin induces the enzymes which are responsible for metabolizing the oral contraceptives. Then the effect of oral contraceptives will not be there. It's a very threatening kind of drug-drug interaction. Similarly, a proton pump inhibitor with ciprofloxacin. Ciprofloxacin, a fluoroquinoline antimicrobial agent, which is sensitive to so many microorganisms. It's a very common practice of the most of the individuals. They use the proton pump inhibitors. And without knowing the importance of the ciprofloxacin, both are taken together. Ciprofloxacin will not able to get into systemic circulation because it is blocking the absorption of the ciprofloxacin. So thereby, the effect of ciprofloxacin, what is very important, is not there, especially in the infections. It's going to be very disastrous. Drug use without indication. It's very commonly seen. Most of the prescriptions contains a proton pump inhibitor, PPI. PPI is not a candy. It is not a chocolate. It's not a peppermint. PPI is proton pump inhibitor, a chemical substance. There are hundreds of evidences. PPI is causing the toxic epidermal necrolysis, which is very, very dangerous, life-threatening adverse drug reaction. Then how come this being misused without having there is a need or an evidence for the medication? Simply prescribing, that's going to be drug use without indication. Untreated indications. I've seen so many cases in my hospital. The hemoglobin levels used to be around 6 gram percentage, 8 gram percentage. They definitely require hematinic formulation. Whether it is generally up to 8 gram percentage, we recommend the parental hematinic preparations. More than 8 gram percentage up to 10, we ask them to recommend the oral formulations. But majority times the hematinics will not be, though it is needed. That is untreated indication. Improper drug selection. Say without evidences, without having the culture sensitivity report, generally antimicrobial agents are being used, and a broad spectrum antimicrobial agent is being used where the pathogen is only gram positive, and when the gram negative infection is there, it is going to become resistant. Then it's a total improper drug selection. Subtherapeutic dose. What is the dose required? Less than that, if the patient receives, definitely the drug does not show any therapeutic impact. So it's a subtherapeutic dose. Failure to receive the drugs. Patients often, they get the prescription. Sometimes they purchase the medicines, but they don't take the medicines because they don't know how to take the medicines. Because of this, there were incidences where the pessaries were consumed because they don't know how to use that medication. It's a very pathetic situation. And the insulin pens are not being properly used. They do not know how to adjust the dose, where to, which part of the body the insulin injection should be taken, whether it is subcutaneous or intramuscular. No one knows. The patients hardly know about it. So it is very essential for them to understand what is their medicine and how to administer the medicine. It's very important. So these 8 categories of drug-related problems are very, very challenging. In fact, they hamper the therapeutic outcome of the medications or the prescription. Now, what is the solution? As already I told you, this is going to cause a lot of taxation to the individual. First thing is, when the patient is not getting the proper benefit, it automatically hampers the health outcomes. Sometimes, as I said, patient got a serious drug-drug interaction, adverse drug reaction, need to go to the hospital. Sometimes in the hospital, the stay may have to be increased. Just for example, patient who is in the ICU, a unwanted drug is being given, it caused adverse drug reaction. Now, in order to minimize the effect of that adverse drug reaction, the patient need to stay for some more days in the hospital. And just it has happened because of the mistake of the consultant or because of the mistake of the nurse, whatever it is. Is the hospital is going to give any report for that? They don't give any rebate. They don't give any discount for that. And they don't accept it as our mistake. And they say just it's a drug issue. Ultimately, who is going to pay for that? Obviously, it is the treatment expenses are going to increase like anything. It's not the treatment expenses. The person will be that suffering. When the patient is in suffering, cannot come back to the normal life and cannot be able to do his normal responsibilities, earn money, and whatever the money is being saved, it's going to be spent there. See, these are all the consequences of drug-related problems. So what is the solution? The simple solution is the clinical pharmacy practice. Many people may think, what clinical pharmacy practice is going to do here? In overseas, like US or Australia, clinical pharmacy practice is in peak. The reason is the healthcare is taken care by the government. Whatever the earnings you have, whatever the taxation you pay for the government, they have made a policy. Two things are made free. One is education up to 12th standard, not up to 12 years of age, up to 12th standard, up to pre-university or 10+2 or intermediate. And up to that, the courses, up to that, the education is free. Schools are free. The next one is healthcare. In Australia, it is 100%. 100% care is provided by the government. Whereas in US, it is 80% is by the government and 20% is by the individual. So they have to pay, and the co-payments where the health care is given 100% care to the patient. So now when it comes to 80% of the money is spent by the government. So unlike India, prescriptions cannot be given just like drug menus. You have to understand the clinical situation, the necessity of the right medication, prescribe accordingly, and follow the patient whether the patient is really gaining the benefit because of the medication or any unwanted effects really causing a concern to the patient. So that's where the consultants, they wanted to have a clinical pharmacist whom considered to be as the therapeutic consultant to work shoulder to shoulder with the doctors. This is where the clinical pharmacists get the recognition, not just by virtue of the name, by virtue of the professional contribution. What I'm talking is about the professional contribution. Doctor will be very confident with his clinical pharmacists because it's my personal experience. When I was undergoing my training in University of North Carolina, in the morning hours before we go into the ward activity, first all the consultants, the junior doctors, senior doctors, the residents and the interns and the clinical pharmacists all will sit in the academic, like we have a clinical case discussion room where all cases are screened. Until diagnosis, the clinicians will put their efforts. At the time of the prescription, they turn to us and ask what is the best medication to be given, how to manage this case. There you are giving your expertise. What is the best medication to be prescribed for the patient? and what are the unwanted medications need to be taken out. So just imagine that is what I said, it's a therapeutic consultation. You being a therapeutic consultant, you are providing the best care to the patients. In that hospital, it is a 350-bedded teaching hospital. It is like a medical college teaching hospital, and it is a state funded, and in the country it is number 2 in rank. They have 35 clinical pharmacists to care that 350 beds. For every 10 beds, one clinical pharmacist. Just imagine. And I was surprised how much money is really going to be spent for the clinical pharmacists. Then I asked the dean, and the dean told me very shocking news that every dollar they spend on a clinical pharmacist, they save $20 to the government in therapeutics by giving the right medication or working on the personalized medication or evidence-based medication. Thereby, they save a lot of money to the government. So that's the reason the clinical pharmacists are on high demand and having a high pay. Well, now coming, how does this clinical pharmacist going to help us? So let us first try to understand what is this clinical pharmacy practice is all about. So clinical pharmacy practice is nothing but, it's not just a classroom teaching. Please try to understand, most of the pharmacy schools in India, they does it's only like a classroom teaching. No, it's not classroom teaching. It's a bedside teaching, especially therapeutics. Okay, because you are expected to work with the multidisciplinary healthcare team, like your doctor, your patient, and of course with your nurse. So with all these three people, even healthcare workers, we have to work with them and try to understand what exactly is the problem with the patient, with the medication, and how these medications need to be properly tailored according to the clinical condition, with an objective to achieve the right patient receives the right medication. Right patient receives the right medication in the right dose. Everything is right. More important is to prevent drug-related issues, because it's not that you, the doctor will give you the prescription, come on, you check. No, you are going along with them to the rounds, and every day you are accessible to the case records. You are accessible to the patient. So you are going through the case record and understanding the case details, clinical details, lab details, and therapeutic details. You are making a proper assessment of that, then to corroborate whether the medicines are really benefiting the patient or not, you do an interview or discuss with the patient. Once you do all these things, you also support the patient to understand the importance of the medication, motivate them to take the medications in the right way. So thereby the patient gets the best benefit of the medication. And this entire activity, what we call as the advocacy or the patient counseling. Why do we need these clinical pharmacy services? Very simple. It maximizes the clinical effect, because you are putting your heart and soul into that, seeing that right medication is given to this patient to get the right effect. So clinical pharmacy is giving them, it is helping in maximizing the clinical effect. What is that is going to happen? That means we are doing good. Minimize the risk of treatment, adverse drug reactions, drug-drug interactions. You are trying to minimize that. So what you are trying to do, you are doing no harm. Minimize the cost of treatment, financial justice. You are making the financial justice to the patient. I told you in US or the Australian situations, because it's all first-hand information to me. First-hand, I worked, I know what is the situation. There, the medications, it's all procured by the government, and there is a proper costing for it, and they don't want to unnecessarily tax the patient. But we can do here cost minimization analysis. Same proton pump inhibitor is available at a cost of 9 rupees to 10 rupees, and the same thing is available even at 2 rupees. the one tablet or one capsule which is costing 10 rupees, where the patient can have 5 capsules of 2 rupees each. Now, who should decide this? A therapeutic consultant, custodian of the medicine, the pharmacist should decide what is the most economical brand which can be recommended. Of course, where the patient can afford, you can definitely, it's a choice of the prescriber to give the costly medicines, because some patients always expect the more the cost of the medication, more is the benefit. All medications are same. From kinetics point of view, dynamics point of view, without these two parameters and the data, the drug control department will not give the permission for the product. So cost minimization analysis will help, and giving the economical product will make a justice, financial justice to the patients. Respecting the choice of the patient, what is needed, it gives them perfect satisfaction, patient satisfaction. This all will be done by the pharmaceutical care. Now, what are the roles and responsibilities of the clinical pharmacist? As a clinical pharmacist, every day my job is to go for the water and participation. It's a wonderful activity. Generally, I used to go to the hospital by 8 o'clock, and 8 to 9, I used to go for the pre-ward activity. What do you mean by this pre-ward activity? Pre-ward activities, say previous evening or the night, probably there might be some changes in the patient clinical condition, might be some new medicines might have been given, or any adverse effect or any other challenge which the patient might have experienced. Accordingly, the treatment might have been changed, but which I don't know. Now, when I go for pre-ward activity, I will know all these things, which I noted down in my patient case records. The clinical pharmacy case records are different, not unlike the patient case records which are put in the patient file. These which documents all the information day-to-day basis, and especially focusing more on the therapeutics. And then we try to analyze what kind of the changes are needed in this treatment. So those things we used to make a note of it on our profile form. Then looking at the treatment, we used to reckon the drug-related challenges. And any drug-related challenges are there, we used to work on the strategies how to minimize. Say, for example, a drug interaction where the drugs are mandatorily required. So just now I just gave you an example of a proton pump inhibitor and then the ciprofloxacin. Simple example, I'm just giving you a quote. Ciprofloxacin is meant for minimizing the infection, which is very much paramount. For me, it is more important. What I generally recommend to the patient or advocate to the patient, because for the proper absorption, the environment in the stomach must be acidic for the fluoroquinones. So I guide the patient to take the ciprofloxacin in the morning without taking the proton pump inhibitor. After 2 hours, the ciprofloxacin gets into the systemic circulation, keeping the stomach empty. Now ciprofloxacin is in the circulation, systemic circulation. It is circulating, it is going to kill the pathogens. Now to minimize the hyperacidity, I can ask patient after 2 hours, you can take the proton pump. It's not going to cause any problem. And now, since the pH is low, that is less than 3.5, then automatically it is going to bring it to the more alkaline type, and it is neutralizing, and patient feels comfortable. This is one strategy which I used to recommend in case if there is a need for a change of the medication. Like I just gave another example, like for example, the rifampicin, which is supposed to, like, a patient who is on oral contraceptives using the rifampicin. Now the best strategy is rifampicin is more important than the oral contraceptives. So I'll advise go for other the family planning strategies than using the oral contraceptives, because here rifampicin is more important. So I make the patient to understand the value of that medication. I guide the patient. They can have a lot of opportunities, a lot of choices which they can use it. So this is how the drug-related problems can be assessed and minimized. Then antimicrobial resistance stewardship. This is another important activity. Like, you have to work with the microbiology department, then look at whether they are doing any culture sensitivity tests, and whether this medication, whether this antimicrobial agent is being put as a prophylactic or treatment purpose. If it is a prophylactic, and correlate or coordinate with the lab, see that the culture sensitivity, what exact antimicrobial agent is asked, or the pathogen shown the sensitivity. Accordingly, you can discuss with the consultant and choose the right antimicrobial agent. Support the clinician giving the correct information regarding the proper antimicrobial agent. That is what is called as the antimicrobial resistance stewardship. Drug information services. Every day, so many articles with respect to the medication usage process, like meta-analysis or the other clinical trial publications, clinical trial finding publications are done. Consultants are very busy with the patient care. They may not have so much of time, but they do have a lot of queries. But who is going to address all these queries? Once again, therapeutic consultant who can evaluate that question, look into the publications, find out the correct answer, synthesize appropriate answer to be given to the consultant, so that that information helps him to prepare a right prescription and improving the patient care. That is what exactly the drug information service. Not that just a doctor asks, you go into the library or Google it, you get the information, just feed it to the doctor. No. Once again, you have to apply that information with that particular patient. And more important, patient counseling. This is another very important professional role of the clinical pharmacist. Talk to every patient in the ward where you are working. Understand them, assist them in giving the right information about the medication usage process. Any doubts are there, clear them, support them in using the medication the right way. Thereby, therapeutic outcomes are achieved and health-related quality of life improves. Hundreds of studies are published. Influence of patient counseling on medication adherence behavior and therapeutic outcomes and improving the health-related quality of life. And globe, so many research publications are there indicating the importance of the patient counseling. Adverse drug reaction reporting and monitoring. We see that, suddenly some patient experiences some unwanted effect. Doctor may feel, it is my prescription caused, so I may be put at guilty. It's not that. Medication, by virtue of its kinetics and dynamics, including the excipients which are present in the medications, are likely to cause unwanted effects which are going to be threatening to the patient's health or even to the life of the patients. So that's why it's very essential for us to understand the need of adverse drug reaction reporting. Don't think that it is only the doctor's responsibility. It is the responsibility of the nursing staff, it is the responsibility of the pharmacists In fact, it's equally the responsibility of the patient. When we started way back in 2003, the adverse drug reaction reporting and monitoring culture in our hospital. So that time, many doctors felt, oh, something is going to be like putting the finger at their side. No. Then we convinced them. We conducted some training programs for the doctors, even for the nursing staff, and for pharmacists. Surprisingly, everybody has a kind of hesitation, inhibition in their mind to do this activity. Finally, believe it or not, we felt who is actually suffering is the patient is suffering, and who should report? The patient should report. Then, in Jesus Hospital, we conducted a culture, and for every prescription in the OP, they get the medication, we used to call them for the counseling and then motivate. Believe it or not, the reporting rate was so high. Then we realized it is patient who's supposed to report more. In fact, that time we are very much in close liaison with the PVPI, and we communicated the same to the PVPI. PVPI also realized, yes, patient reporting is very important. Then they have come out with the patient report format also. These are all the professional responsibilities of the clinical pharmacist. I'm going to explain to you each and every one. So here the photograph which I'm showing, it's all my clinical pharmacists and my consultant and me who are, I used to work in different departments. Like this is my neurology posting where we used to work with my consultants. And what is more important here, it is not going for the rounds is important. It is your intervention is very important. You have to understand the patient, clinical condition, the manifestations what the patient is having, and any planned investigations are there. And accordingly, the prescription what is being given is appropriately given according to the patient need or not. Then any queries there, you talk to the doctor, give the appropriate information so that his prescription is going to be a proper prescription. That is where you are going to optimize the drug treatments. This is the heart of the clinical pharmacist job, medication chart review. When you go for the round what activity, this is what is going to happen. It's a fundamental responsibility of the clinical pharmacist. Why you want to do this? When you review the patient case record, you come to understand what exactly patient requires according to the clinical condition, what medications is needed. So the appropriate drug in correct dose and suitable dosage form to be given. Say, for example, if patient cannot consume a medication, swallow the medication, then if an alternative syrup is available, just convey the message to the consultant so that the oral formulation it will be changed like from the solid dosage form to the liquid dosage form. So this is how, as a clinical pharmacist, you can work and you can optimize the timing and duration of the therapy, how long the medication need to be given to get the best clinical outcomes. And understand the prescription, assess drug-related issues, try to minimize the drug-related issues with the doctor. Drug information, I told you, volumes of information is published every day. You just believe me. Almost 20,000 biomedical journals are published every year. Is it really possible for a clinician to go through all these 20,000 biomedical journals? It's very difficult even to go through at least few journals. Unless otherwise, clinically, they need some expertized information. So, it is we, the clinical pharmacists, are having that opportunity. What are we going to do? We can provide great, unbiased. We are not talking any medication in favor of any company. It is only as a medication we are talking. We refer them. The proper literature review is done. We critically evaluate it, and up-to-date information on any aspect of the drug usage we are going to give to the consultant. And the objective of this is to provide accurate, relevant information contributing to the patient care. For example, here I'm just giving a clinical situation so that you can understand what is the value of the drug information. So here, a situation like a nursing mother who's suffering from gastroenteritis, the consultant has prescribed ciprofloxacin. Now the question is, can the ciprofloxacin be given to the nursing nurse? Ciprofloxacin, all fluoroquinolines belongs to the category C. Category C, D are contraindicated in pregnant women or nursing mothers. So the literature explains that ciprofloxacin is a category C medication contraindicated in nursing mother due to a potential for arthropathy in the baby. That bone softening will happen. A child who is growing, if the bones are very soft, and if the child fell down, there is a fracture. So, is it really necessary? Because ciprofloxacin secretes into the breast milk and the baby is suckling. So, when the ciprofloxacin gets into the systemic circulation, it is going to damage the bones. So, that is what is the reason it should not be given. Then, okay, now you say, no, ciprofloxacin cannot be given. Then what should be given? That's the most important. It is not that you say, no, it should not be given. It's equally important, more important, in my opinion, to say that what is more essential to be given. Essential to be given, it is the azithromycin, a macrolide 1 gram on the day 1, followed by 500 milligrams OD for the next 6 days. It is going to clear the gastroenteritis. This is how you have to come out with a ready-made strategy in case if that does not work, what best works. We have to have the clarity. As I told you, we are the therapeutic consultants. We have to have this back of our mind and work accordingly. Next is another clinical situation. A 78-year-old male patient suffering from the type 2 diabetes mellitus and COPD with septic shock. The laboratory values suggest serum creatinine is 3.6 milligram per deciliter. Every clinical pharmacist, even clinical pharmacy students knows, especially those who have completed 4th year, they know what is this serum creatinine. Serum creatinine, it is a marker of the renal functioning, because every day the cells are died and these cells are metabolized and excreted. When they are broken down, ultimately serum creatinine is produced. And there is a value, say 0.8 to 1.4 milligram per deciliter of serum creatinine secretion is a normal, because it is a normal process of cell death and cell elimination. But if serum creatinine value exceeds more than 1.4 milligram per deciliter, indicating that there is some problem with the kidney excretion. So, to assess the renal functioning, we use the serum creatinine as a marker. And if you take this value, applying the Cockcroft-Gault formula, we know what is the glomerular filtration rate. And it is supposed to be around 14.85 milliliter per minute, which is supposed to be more than 80 ml per minute is the normal case, indicating that the renal function is like, it's a chronic renal failure situation. So now what to be done? Because you are giving the amikacin secretes through the kidney and eliminates through the kidney. So obviously the kidney functioning is decreased. Now can we give the normal dose of amikacin? No. You have to adjust the dose. This adjustment is your clinical efficiency, your therapeutic efficiency. And accordingly, if we calculate, instead of actually it comes 750 milligram BD dose, but we cannot give 750 milligram BD dose. We have to give only 250 milligram OD in this patient to suppress the infection. Similarly, in oncology, like patient with the carcinoma of the stomach. So this is the recommendation. This is the regimen which is given. Most important is the height and weight chart, which helps us to calculate the body surface area. According to the body surface area, the dose must be calculated for the patient. When we calculate, we can give appropriately the medication, including what is the diluent fluid, what flow rate it should be given. See, administration guidelines we can calculate, we can just record, and accordingly the drug administration can be done. This is what is the beauty of the drug information service. Next is the patient counseling. Patient counseling is where the patient, actually many patients may not be knowing, so they want the information. This information should be in layman language, not in the pharmacological terms. So when you give the information in a simple layman language, either orally or written form, to the patients or patient representatives with respect to the medication usage, with respect to the diet, with respect to the lifestyle modifications. If you give this information, it's going to be a perfect thing. The patient is going to get the best benefit. What are the benefits the patient is going to derive by giving this? Like, it improves the patient medication adherence. Medication adherence behavior will be improved by proper education, proper consoling to the patient. Thereby, medication benefits are experienced by the patient. Improves health-related quality of life. Everything is finally related to the quality of life. Keeping the person healthy, enjoying, but it is only feasible when the person is having the proper health. Guiding the patients, like for example, the small stickers, you can apply, you can put the usage instructions for the medication. Like for example, take this medicine at bedtime, take this medicine on empty stomach, take this medicine soon after you take the food or along with food. Then patient information leaflets or the posters which you can prepare, put it in your ward or in your counseling room. Then you can help the patients to use the inhalers appropriately or how to use the eye drops appropriately. Now, in fact, we have done a lot of work on these educational tools. I conducted one study on the proper usage of the inhalers, which got a national best research paper award way back in I think in 2006, because we just feel that patients know everything. Patients may not be knowing. Please, we have to understand that patients are not knowing everything about the medication. We should educate them for the safe usage. When I did this study as a randomized control study, I segregated some people into the test and some people into the control group. The control group were just asked to use the inhaler as they know. And for the test people, I educated them. Believe it or not, after 2 months of our training, and every month we used to take the FE1 values. When we have calculated that post expiratory volume first second, tremendously improved in the patients who got educated, because I trained them how to hold the inhaler, how to press the canister, what are the different steps to inhale the medication inside. Thereby, the lung function test dramatically improved in these patients, showing that the outcome is excellent. That is what you call statistically significant outcome was observed in these cases. Adverse drug reactions. I explained to you these three conditions. This is angioedema and this charring you can see on the skin. This charring is called as toxic epidermal necrolysis. And this baby was suffering from Steven-Johnson syndrome after the first dose of cefixime injection when it was given to the baby. Does any patient want this kind of a situation? They want the benefit of the medication. But these are all due to the medication, these consequences. And They are called as the adverse drug reactions. When they are used in the normal therapeutic dose, not overdose, in normal therapeutic dose for the purpose of prophylactic or diagnostic or therapeutic purpose, this kind of the situation, when it comes, it is called as the adverse drug reaction. And what is the responsibility of the clinical pharmacist? Detect, assess, correlate, manage, document, and prevent adverse drug reactions for further. See, if I come across, I have a wonderful experience during my ward activity. One of the patients were like pneumonia symptoms were there, and the patient got admitted, and patient was treated with the antimicrobial agents, but patient was not responding, and finally doctor felt why not we go for the to confirm the tuberculosis. Then AFB was done, and AFB came positive. Then immediately stopped all the antimicrobials, and we shifted the patient to receive the ATT, anti-tubercular therapy. Anti-tubercular therapy contains 4 drugs: rifampicin, isoniazid, ethambutol, and pyrazinamide. 4 medications. These 4 medications to be taken once daily dose. Only once daily. All 4 medications. 3 days passed, patient was okay, and 4th day we found the patient was dancing on the bed. It was a surprise to us, and the doctor was shocked. "Arey, what is this happened?" Then immediately asked the PG to refer this case to the psychiatry department. Then after our rounds, when I went back to my department, I was thinking about this patient. All 4 days was all right. Suddenly on 4th day, why this has happened? What made him to behave like that? Then I went on searching the information. In FDA alert, somewhere I got isoniazid can cause psychosis. Very rare reaction. Immediately I further researched, I got more information, and by lunchtime, I collected all the information. Soon after the lunch, I went to my consultant, and then I explained everything about this and shown all the evidences. Then immediately called the PG whether the patient was referred to the psychiatric department. He said, no, he's just preparing. So asked him to stop and said, you just stop the medications. Don't give the ATT anymore. Just to stop, wait for some time. Then after 2 days, the patient was normal. Now the challenge is, it's a D challenge. We have stopped the medication. Question is to confirm, can we re-challenge? It's a big ethical issue. Putting the patient once again onto this clinical situation, can we ask, can we feel, can we also go into that situation? We cannot accept. Then why should we make the patient to suffer further? So what we did is, we stopped the isoniazid and we continued with other 3 medications. Then we have got a good result. So this is where, we have to put time for every patient. We have to monitor, is this medicine is perfect? Is the patient is happy with this medication? Every next day when I go to wards, I used to ask my question. I asked to my patients, are you comfortable yesterday? Are you happy with your medication? Are you feeling comfortable today? Are you able to just do your routines normal? See, this is what happens, it builds a kind of relationship between you and the patient. So here, as a clinical pharmacist, we have to put time, energy to understand the case, understand the medication usage, understand by any chance any unwanted effects are there, track them, capture that, assess the causality, assess the preventability, and then inform to the doctor, then report it to the AMC, Adverse Drug Reaction Monitoring Center. Generally, most of the teaching hospitals nowadays, they are granted by the PV to have AMCs. If AMC is not there, report to the nearby AMC. What is the wrong in that? Then, to prevent re-exposure to the patient, how can we do? Giving, always we used to maintain a alert card to the patient. We used to give an alert card with the name of the patient, age, and what medicine he was sensitive. And we used to ask the patient to carry this all the times. Whenever you go to any doctor, show this card, so that by any chance, if this medicine is really, the doctor will not prescribe, because this medicine is going to trigger once again the problem. And try to minimize or prevent the expenses, because don't think that, oh, it's an adverse drug reaction. Just you have seen the charred clinical condition, like, the toxic epidermal necrolysis. Just imagine an individual who have this toxic epidermal necrolysis, how much money, time he has to spend to come back to the normal skin condition. So much of money is spent. Consultation charges, medication charges, and a lot of time. And just imagine what kind of the other challenges the patient need to have. Therapeutic drug monitoring is another important area, but we really in India don't do it. It's especially with the narrow therapeutic index of drugs, we generally do this kind of the work, and where the therapeutic very less, the range is very less. We try to, but this kind of the service is done in Vellore. Vellore it is happening, but otherwise in no hospital it is happening in India. The objective of this service is to optimize the drug therapy for drugs which are having the narrow therapeutic index, and drug toxicity can be minimized to assess the potential drug interactions and adverse drug reactions. Because the range, the plasma concentration range is very, very small. The window period is very less. Just slight enhance leads to adverse effects. Slight decrease, then the required, then it is going to cause unwanted adverse drug reactions and drug interactions. So, as a clinical pharmacist, you are going to support nurses, the clinician, and as a pharmacy. You may ask how you are going to support pharmacy, because it's a wonderful service you can do. You, like in your ward, maybe 10 patients or 15 patients, 20 patients, because we used to work with the 20 patients. So all prescriptions were sent to the pharmacy. So we used to go to the pharmacy, check whether the right medication is filled for the prescription, monitor it. Then appropriately, after our checking, medicines used to be sent to the ward, and we also used to work with the nurses to see that at right time the medication is being administered. And we have done very good research work on drug administration errors. We found a lot of reasons and educated the nurses how to minimize them. Clinicians, every day the work is with them, so always have to have a very good relationship. In fact, we used to spend a lot of time in case discussions, where the doctors used to feel very happy, on par with their PGs and on par with their interns and the junior doctors. Of course, with patient, we used to work in most best way. The question is, are clinical pharmacy services are really good? These services are more important in like they are at the peak in US, UK, and Australia. But why it is not in India, I'll tell you later. Outcomes of the clinical pharmacy services: decreased adverse drug reactions, decreased medication errors, decreased healthcare costs, decreased re-hospital admissions. That is most important. Once you got admitted, then once again, because there is a challenge, drug-related challenge, once again you are brought back to the hospital. That kind of the admissions are minimized and decrease the morbidity and mortality. Now, there are so many publications, research evidences showing the usefulness of the clinical pharmacy services. Instead of medicine, it says the air is human. Yeah, we are more likely to, we are tend to make mistakes, but it is more important to correct the mistakes. And the mistake corrections can be done by the pharmacists, especially in the prescriptions. So, there was a study in it's a kind of systematic review. The systematic review was published in Pharmacotherapy in 2014 with respect to the clinical pharmacy services and the drug-related issues and the economic benefit. And it said very clearly They said huge financial benefits are seen because of the clinical pharmacy services. And HEOR, humanistic, economical outcome, that is health outcomes research. So there are so many benefits are seen with this kind of the services. It's in Australia, a study was conducted, and the study says that because of the clinical pharmacy services, the annualized cost savings to the hospital, 8 major acute care teaching hospitals in Australia, it saved almost $4 million to the government. That's excellent. Just imagine so much of money is being saved. And there is a huge reduction of the medication errors. It's from almost 65% decrease in once again in a US hospital because of the presence of the clinical. Healthcare costs and length of the stay is decreased significantly because of the clinical functions participation. And there is a 78% fewer preventable adverse drug events occurred among the patients in a hospital general medicine unit when a pharmacist participated in a weekday medical rounds. Preventable adverse drug events in ICU decreased by 66% when pharmacist was present on rounds as a full member of the patient care team. Pharmacists providing pharmacy care in 1,000 US hospitals saved nearly 400 lives and $5.1 billion as healthcare costs. Just imagine what a kind of contribution by the clinical pharmacists. And patients treated with the blood thinners in a pharmacist managed anticoagulation clinic had fewer emergency room visits and hospitalizations, resulting in total cost saving of $1,621 per patient, not overall. Pharmacist medication recommendations improved clinical outcomes in over 30% of the cases at a Veterans Administrative Medical Center, saving more than $420,000. And hospitals save nearly $17 in benefits to the patients for each dollar invested in clinical pharmacy services. That's what I told you. In University of North Carolina, I just asked, how can you manage 35 clinical pharmacies? They said, no, it is this much they are going to save when they are going to save so much of money. There's no problem. You know what is the cost of a clinical pharmacist? A regular clinical pharmacist earns nearly almost 150,000 to 200,000 US dollars per annum for a clinical. That is the money they are offering. And if you are an oncology clinical pharmacist, you are a nephrology clinical pharmacist, are a specialist in infectious diseases, you draw more than $200,000. Depends upon your experience, expertise, your the knowledge and skill what you have. Yes, hospitals are ready to pay for that because I told you 20 times they are going to save the money because of your service. Pharmacists providing pharmacy care to the patients in ambulatory clinics saved nearly $250,000 in 1 month. Pharmacists collaborating with physicians to care high-risk patients reduced the number of prescriptions per patient and saved nearly $600 per patient per year in drug costs. And pharmacy services saved $75,000 in 3 months and prevented additional medical problems from occurring by identifying prescribing errors. So, friends, there is a huge thing which we can do, but the challenge in India, because PharmD program is offered in more than 400 institutions spanning. Question is, I come across so many students, I talk to them, they say that they don't go to the wards. They got in a hospital for the sake of approval, but these students are not permitted in the hospital to review the cases, to participate in the rounds. Yes, this is the reality. If this is the situation, how the clinical pharmacy competences can be built in, that is very important. Now, here we need to have a good preceptor who is trained and who can educate the patients, train the patients, improve their competencies. So thereby, pharmacists, the clinical pharmacists, are readily accepted in the society. Please don't tell me that no hospitals they don't take. I understand, but recently I attended one. The CAHO conducted this training program for the clinical pharmacists in one of the corporate hospitals in Hyderabad. I realized the hospital administration wants clinical pharmacists, and they have also just put a query that whether the pharmacists are competent enough. Because when you are working with the doctor, you have to talk to them confidently about the medication use. How many students they have the competency of talking to the doctor confidently and able to analyze the drug-related issue and able to dissect and able to minimize, say the strategy to the doctor. See, this is what is important now. And that's where the mentors are required. Mentors will guide you how to improvise your therapeutics knowledge. Case-based understanding is more important. And applying what you have learned in the clinical situation is further important. So this all can be cultivated with the help of a proper preceptor. So who is going to help you in preparing the introductory pharmacy practice exposure and advanced pharmacy practice exposure and support you in grooming your clinical pharmacy competencies? Say, for example, giving a prescription and asking you to analyze any regulated issues and coming out with the strategies to minimize the regulated issues. Then talk to a patient, like counseling the patient. If any query is given, how do you provide a proper drug information? Evaluate all your skills, support your learning, make you more competent. That is what the preceptor is supposed to do, which we wanted to help you. And we wanted to help you in understanding what is clerkship book and log book, how you can how you can improvise in doing your activity and documenting it and understanding from the documentation to improvise yourself. Say, coming to an end, I just want you to understand, end of this lecture, India is a country with many drug use problems. Today, paper said 146 crore population is the India's population. This is today's paper data I'm telling. Even if you consider just 10% of the population is having the diseases, according to the survey, every 15 is a diabetic. That means 20% of Indians are diabetics. 20% of Indians are diabetics. 146, 14.6, 14.6. If we calculate 28, that is 29.2 crores are only diabetics. What about the hypertensives? What about the asthmatics? What about the COPD patients? What about the patients with the liver challenges, patients with the kidney challenges? There is so many patients with a lot of drug usage. Whenever the drug usages are there, drug use problems are also there. And where you have a lot of opportunity to support the patients in giving the right prescription. There is a need for clinical pharmacy services in hospitals. Then clinical pharmacies definitely add a lot of value in the healthcare system. Only thing is we have to prove ourselves. Only then this is going to happen. Don't expect that the ready-made dish is and given to us. No, we have to make our own dish. We have to create value for us, and we have to showcase our value. Then people will accept you. Okay. So with this, I just thank the Clinosol to conduct this kind of a program. Hope you might have got the right information to you. And in case if you have any questions, any kind of doubts, I'm ready to answer. In chat, I think there are some things are mentioned. I don't know what is this. Nice presentation. See, I'm not interested in having this presentation. I am interested if you are in need of improving your competencies, just talk to me. I'll give you how to build yourself as a better clinical pharmacists. That's all. I don't want any kind of praises for my presentation. This is not one single presentation. This kind of the presentations are made thousands. Pan-Indian, so many incidences, so many platforms. I talk to the doctors, I talk to nurses, I talk to the clinical pharmacists and community pharmacists. So this is not a big deal. But what my vision is, my dream is, we the clinical pharmacists take the leadership role, work shoulder to shoulder with the doctors and care the patients. Make ourselves like identified by the doctors and the society. Then the government has to like create the clinical pharmacy. There is opportunity. As a hospital pharmacy division chairperson, I am doing my best efforts reaching to the Ministry of Health and trying to convince, because once again, the government will question, okay, we want to appoint the clinical pharmacists. What is the benefit the government is going to get? Because PharmD program is there, we need not have to appoint clinical pharmacists. We have to show the evidences that how much money we are going to save to the government. Pharmacoeconomic studies are. This is what I request many of my colleagues pan India who are working for the institutions. Please focus some time on the pharmacoeconomic success. Come out with the data, then compile the data. Let us go to the ministry and convince this much of money we can save, this much of health outcomes we can improvise. Then yes, it is going to. So thanks a lot for the presentation, people who are here. If you have any queries, please, you don't hesitate. You can ask me the queries. Thank you very much. Are you there? Anybody is there, or everybody is muted, not to speak anything? Who is there? Hello?
Yes, sir. Sir,
Yeah.
all the participants are on mute, sir. They can ask their questions in the chat box.
Pardon?
All the participants are muted, sir. Whatever they have questions, they can post in the chat box, sir.
Yeah, they can post in the chat box. I've also given my mail ID to you.
Okay.
In the very first slide, the first slide, I just put my mail ID. You can even send your queries through the mail. I will definitely answer your queries. Don't hesitate. It is my responsibility because you're all budding clinical farms. I'm hoping on you. You definitely deserve to have the right answer. You can unmute them. There's no problem. No? Is there any challenge if we unmute?
I'll check, sir.
Yeah, please.
Hello, sir.
Okay.
Good evening.
You can go to- Yeah.
Sir,
Yes, please.
yes, sir, I would like to ask. You said about the prophylactic antibiotics, right? So,
Yes,
the
please.
prophylactic antibiotics are given generally in OT reception or ICCU before the surgeries to prevent the infection, not the
Yeah.
like the existing infections. They can't be treated prophylactic antibiotics, right?
No. You should understand what is prophylaxis means. Say, for example, a patient has come to the clinician and patient found to have an infection, but we don't know what is the pathogen actually caused that infection. But we cannot just make the patient to wait until we confirm what pathogen is actually responsible for that infection. Say, generally, culture sensitivity take tests.
Oh yeah, awesome.
Say, generally, which is going to help the patient to minimize that kind of the effect. So thereby, within 2-3 days, this can be managed. And once you get the culture sensitivity report, and then you can shift to other antimicrobial agent, which is really highly sensitive to that pathogen. Yeah, this can be done.
Okay,
This is
sir.
what is called as a prophylaxis.
Okay,
And
sir.
once you confirm, say for example, now you said in case of emergencies like ICU, yeah, there you cannot take any risk, you cannot take any challenge. You have to just start treatment, see that the best medication to be given so that the pathogen can come. Yeah, meanwhile also you can take the swabs, or you can send that for the culture sensitivity test and see whether generally they start treating, but simultaneously the sample will be sent for the culture sensitivity test. It is also will be possible because medical care is important there.
Sir, I have a question. Like, what if, before the surgery, the prophylactic antibiotic is not given in the correct dose? Like, for example, the Monosef, other drugs, 1 gram or 2 gram, if they are given in high dose or very much low dose, but not the adequate dose, which should be given before the surgery. What happens in those cases?
Generally, before the surgery, antimicrobial usage is very limited. I don't think they just give it because there are, yeah, in case if there is an infection and you have to take the patient to the surgery, and in general, the clinicians or the prescribers will give the antibiotics full dose because there are therapeutic guidelines. Majority times they follow the guidelines. What challenges, what chances of giving the low dose? I did not come across that kind of a situation because we also used to participate in this kind of the situations where surgeries are planned and antimicrobials are need to be given. So then they will consult us like what to be given. So we advocate to them and right medication in the right dose is to be given. So I did not come across, but in case, yeah, there was some situations after the surgery we got the culture sensitivity report, then immediately stop this medication, shift to the medication which is highly sensitive to that pathogen. Yeah, that kind of the changes we have made.
Okay, sir. Thank you.
Any more questions? This is an interactive session, and you're all, I'm just hoping you're all the budding clinical pharmacists having a great hope on your future. If you have any doubts, please don't hesitate. You can ask. Yes.
So one more question.
Yeah,
If a
is your good
patient,
name? Your good name, and are you a student or a practicing pharmacist? What is that you can
I am a student, sir. I am doing my family 6th year. I'm an intern in a hospital, working as a clinical pharmacist right now. Internship.
internship? You are
Yeah,
from
I
which
just
college?
started my internship. Sultanul College of Pharmacy, sir.
Okay, 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 good. Tell me.
Sir, actually, I wanted to ask. I just came across a case where a patient was on antibiotic meropenem. So,
Hmm.
the day which he has taken the meropenem, after some time only he had developed a reaction. So, they had
Hmm.
stopped the meropenem.
Hmm.
After that, they did not give any antibiotics for him. So,
Hmm. Hmm.
will the infection, the infection will decrease, or uh,
Here, yeah, your question is a very valid question, important question. Now, yeah, this imipenem like meropenem. Generally, it is recommended for the septicemias, like the infections which are there in the blood. Septicemias, it's an excellent medication. It is going to clear that. But if any adverse event, definitely it is likely to cause an event. So in that situation, best thing is to stop that medication. But does not mean that you have to stop. If there is an infection, you have to shift over to the next best antimicrobial agent which are sensitive to that pathogen and can definitely control that infection. We cannot say that we should not deprive the patient having the benefit of antimicrobial agent because they are going to minimize the risk of infection. No? So obviously it should be done. We have to rework. Very simple.
Okay, sir. Thank you, sir.
Hello, sir.
Yes, please. Can you please introduce yourself?
My name is Suhana. I'm a family intern from KLE College of Pharmacy, Hubballi.
Hubli. Okay.
Yes, sir.
Good, good. In Hubli, they
Um,
started PharmD.
yes, sir. In KLE College of Pharmacy, it is there, sir.
Yeah, okay. I know. Because I worked in Mysore for a long time. I have a lot of friends in Ely University. I was a
Yes,
regular
sir.
visitor there.
Yes, sir. So it started since I guess 2017, I guess, in
Okay.
KLE College of Pharmacy.
Okay.
Sir, I
Please, you can
wanted to
ask the
ask,
question. Hmm.
like a few days ago, I came across an ADR, which
Hmm.
was phenytoin-induced DRESS syndrome, Steven-Johnson syndrome.
Hmm. Yeah, it is
So,
possible.
yes, sir. So, while uploading ADRs in Vigiflow,
Hmm.
like they have assigned us to upload the ADRs on Vigiflow. So
Yeah,
there
because it's a
is,
PVPI software.
yes,
So
sir.
those if you have the AMC, then you have to connect with the Vigiflow and
Yes, sir.
you should upload the information.
Yes, sir. Our college is an AMC, sir.
Yeah.
Yes, sir. So there is an option we have to select like probable, likely, unlikely, like how
Hmm.
what kind of ADR it is.
Exactly.
So I have a question on that. Sometimes I don't get it, like how I assess that it is probable because of drug only, or like if it is unlikely or likely. So do you have any tips on assessing the ADR in that category, sir?
Yes, madam. In fourth year, you have to study the chapter called as pharmacovigilance in clinical pharmacy practice.
Yes,
Do you
sir.
have that subject, clinical pharmacy
Yes, sir.
practice?
Yes, sir. Yes,
Have
sir.
you studied the pharmacovigilance ADR monitoring and reporting,
Yes, sir.
in which we teach you the causality assessment
Okay.
scales
Yes, sir.
like
Scales. Yes, sir.
Naranjo, WHO punitive scale, Carson-Lazarno scale. So these
Yes, sir.
scales empowers you to assess the causality, whether it is certain, probable, possible, uncertain, unlikely. These kind of outcomes you can assess and you can report. And I always recommend when you are in the ward for every patient when you are doing the clerkship in fifth year, no, because
Yes, sir.
you are taught only all these concepts in the fourth year. When you start your clerkship, every
Yes, sir.
patient you start doing this kind of the activity, you'll become a kind of expertise using this causality assessment tools. And when you go for a job in the pharmacovigilance area, they ask you these questions only. And
Yes, sir.
you will also be asked about the signal. What do you mean by the signal? Signal is an event where first time the individual has experienced some un like unwanted this exposure, unwanted this feeling, then it is a signal. So if it is for a new drug, that signal is going to be very important. Or sometimes the rare adverse drug reactions can be detected by using that signals. Okay. So this knowledge is very, very important. You have to apply this causality assessments. You have a lot of scales, like for example, causality, then preventability and severity. For assessing all these, the scales are available, and it is there in
Yes.
the textbook of clinical pharmacy by Parth Sarthi, Kerin Naifut Hansen. So there is a textbook of clinical pharmacy. In that, it is
Yes,
being
sir.
given. Or if you
Yes, sir.
want those scales, you have my mail ID. You can just put me a mail. I'll send you all the scales to you.
Yes, sir. Sure, sir.
Okay.
Thank you so much, sir. Thank
Yeah.
you for addressing my questions.
Yes. Anybody? All the budding
Hello,
professionals are silent means we are not progressing in the profession. Please make yourself charged and be proactive. Yeah.
myself Sheikh Faisal from Bangalore,
Okay. Good.
Karnataka College of Pharmacy. I have been placed as a student
You are from
AMC
which
called
college? Just once again, you are from which college?
Karnataka College of Pharmacy. Karnataka
Huh?
College of Pharmacy.
Government College of Pharmacy. Yeah.
Karnataka College of Pharmacy.
Okay. 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 Kannada colleges. That is. Yeah. I remember. Okay. Hmm.
Uh, so I have been placed in dermatology OPD for
Okay.
AMC coordinator. So
Okay.
I have been reporting all the ADRs till now in dermatological department. But the thing is,
Yes.
what I'm saying here is, as you said that you have been implemented an ADR card in any one of
Alert
your
card. Alert
hospitals.
card.
Alert card, yeah, alert card.
Yeah.
I'm facing a problem with that, sir. I couldn't implement that.
Hmm. No, I'm
So can
sorry. I
you
could not
like,
catch your question. You are in the dermatology department.
sir,
You wanted.
I want your guidance in implementation of ADR alert card because here
Okay.
it's not going on.
You can prepare an alert card. There is no some what do you call rocket science in it. What is simple you need to do is make a small slip in which write the name of the patient for the drug which the patient got the ADR. Write the name of the drug, patient address, or if the clinician wants to contact you, you give your number and explain what kind of event has happened there. A small card type of the thing you can prepare, or if you want, you can even since you are in the Karnataka College of Pharmacy, who is your principal?
Dr. K. Ramesh,
Yeah, I know him, Dr. K. Ramesh. You can connect with the JSS. In JSS, we have these kind of the models. By any chance, if you have anybody whom you know in JSS, or you can straight away write to the clinical pharmacy department, JSS College of Pharmacy, they will send you this model of the alert card. There is no problem. Or else, even I can send you the alert card model. It's not a big deal. I told you, no, it is not rocket science. You can make your own card. You can design it with your hospital name and college logo, hospital logo, and all this information, name of the patient, clinical condition, drugs prescribed, and what drug which caused the event. That you can explain everything and give an like a statement saying that the patient with this medication found to have ADR. So please careful while using this medication because next time the ADR is going to be very serious. So you can just alert the doctor who is going to prescribe next time the medication to the patient.
thank you, sir. Thank you, sir. I'll do that.
Yeah, good luck. Any more questions, please?
Hello, good evening, sir.
Yeah.
Firstly, I thank you for this sub informative session. I want to ask you that is it necessary to us to do any other courses like pharmacovigilance as we have already studying in our this all over 6 years of PharmD. So we have to do any other additional courses, certified courses
See, one thing is,
to know in depth.
yeah, I understand. I'll
जी.
just tell you one very important message to you. Like, most of the medical doctors like who complete MBBS. They go for some advanced specializations like general medicine or the pediatrics, gynecology, pulmonology, gastroenterology, like specialities are there. They do it. Now, with medicine exposure to the medicine MBBS, once upon a time, that was the primary qualification to do everything. And those days, it was all family physician concept, a general practitioner's concept. But now it is more of the specialist concept. So here, if you want to become an expertise in one particular area, in PharmD, I know you are exposed. In fourth year, you are given a concept on pharmacovigilance, a concept on the patient counseling, concept on the drug information, concept on lab data interpretation. All those things are taught. But when you come to the fifth year clerkship, how sincerely you have done that job, that's very important question. It is not that I'm just challenging you or I'm just pointing at you. I'm just telling you, if you have done it systematically, I really appreciate you. Second point is, if with that knowledge, if you are able to crack an interview, getting into pharmacovigilance as a drug safety associate, or getting into clinical research as a clinical trial associate, whatever that job you are, getting into the hospital as a clinical pharmacist, it is well and good. Once again, what happens is, no, when you wanted to master that concept, you need to have an additional skill. So this additional skill, competency comes only continuing professional development or with additional courses. So these additional courses empowers you with the additional knowledge and skills. So that is where you are encouraged to do the programs. So generally, why we have to do, say for example, I have done my masters in clinical pharmacy. I did my masters in, I did my doctorate in clinical pharmacy. Still, do I need to upgrade my knowledge and competencies? Definitely. Every day is I'm a student. Despite having so many years of experience, still I'm a student because every day is a new challenge, new patients. Say if I wanted to upgrade myself, upskill myself, so I have to take the concepts. That is very, very important for any professional career. Okay.
Okay. Yes, sir. Thank you very much.
You are from which place?
I'm from RBVRR Women's College of Pharmacy, Hyderabad.
Hyderabad. Okay.
Yes. RBVRR Women's College of
Yeah, I know,
Pharmacy.
I know, I know. I know.
Hmm.
Sumakant.
Yes. Yes, ma'am. Yes, sir.
Okay.
Yes.
Hello.
So, yes, please. It's raining. It is drizzling, not just drizzling. It's raining. A lot of thunderstorms are there. So, I think if you have any queries, please push those queries through my mail ID. I will definitely answer you. Don't worry. You can definitely get the correct information or any additional resources which are needed to be given. I'll send it to you. Don't worry. Okay. Thank you very much. Yes, please. So I just wanted to, because it is drizzling heavily and there are a lot of thunderstorms are here. So I'm just worried. The net is likely to be disturbed. So I just request you, if any questions are there, please push my mail through my mail ID. You I have given you, it is very simple. adepu63@gmail.com. adepu63@gmail.com. You can ask, it's all professional queries. I will definitely support you in learning. Okay. Thank you very much.
Thank you so much, sir. On behalf
Bye.
of Clinosol Research, I would
Thank
like
you
to
very much,
sincerely
Mr.
thank
Sunil.
you, sir.
Thank you, sir.
And thank you, Mujib sir, and all the participants. Thank you for being the part of this session. We are looking forward for more sessions. Thanks a lot, sir, again.
Okay, bye.
Have a good night, everyone.
Thank you.
Hello.